Well, hello everyone, and welcome to another episode of EIJ on Air. My name is Mirvat Alasnag, and I'm an interventional cardiologist practicing in Saudi Arabia. And with me today is Giuseppe Tarantini. He is a interventional cardiologist at the Department of Cardiac, Thoracic, and Vascular Sciences and Public Health, University of Padova in Italy. Welcome, Giuseppe.
Hi, everyone. Hi, Mirvat.
So we'll be discussing the clinical consensus statement from the European Association of Percutaneous Cardiovascular Interventions that was elaborated in collaboration with the ESC Working Group on Cardiovascular Surgery on the management of coronary artery disease in patients undergoing transcatheter aortic valve implantation, which was recently published in the Eurointervention Journal. So I think at the outset, Giuseppe, it's important for us to consider what is the burden of coronary artery disease in patients undergoing transcatheter replacement. Does it really warrant the elaboration of a consensus document?
Thank you for this point. So actually the burden of coronary artery disease in patients with severe aortic stenosis is significant for at least three reasons. The first one is the prevalence, and we're going to discuss that. Secondly, the impact on periprocedural, period of TAVI, and actually looking at the prognosis of the TAVI. But sticking to the prevalence, I think that we need to spend some words more in this regard, because actually, the variability of the prevalence is quite significant. And the range is between 15 to 25% when we deal with low-risk patients enrolled in randomized trial, like the PARTNER 3 low-risk valve. But actually, this prevalence goes up to 80% in extreme high-risk cord valve trials. And when you look at the registry, it's about 60%. So this variability is significant also if you consider that in a randomized trial, for instance, in a low-risk trial, patients with symptom score above 22 and left main or recent revascularization was an exclusion criteria. So actually we have some kind of heterogeneity that actually for sure the burden is significant.
So in addition to that, there's significant variability between centers in the evaluation of coronary disease prior to TAVR. And so as such, what do the experts of this document recommend for the assessment of coronary disease in this kind of a patient population?
So actually, this is another important point, because the focus of this document is to be very pragmatic and to be useful as operative guide for interventional cardiology. To make some clarity in this regard, actually, we have to state that the gold standard, as also recommended by guidelines, is the invasive angiography. So the patient with severe aortic stenosis who will undergo TAVR or surgical intervention, actually mainly as based on the consensus recommendation in patients with the evidence of ischemia, left main, or actually we have an acute coronary syndrome, or, men older than 40 years old or postmenopausal in case of women. So the point is that this is the gold standard, but actually we have also non-invasive way to evaluate the coronary artery disease, like the CT scan. But actually considering that the positive predictive value is low, is about 60–65%, and the negative predictive value of the CT scan is about 99%. It is useful to use a CT scan in patients younger and with low risk of cardiovascular disease. So actually, this is the recommendation of using non-invasive tests for evaluating coronary artery disease in the setting of TAVI patients.
So is there a role for invasive coronary physiologic assessment? And if so, what are the limitations of using intracoronary physiology in these patients?
This is a very intriguing chapter of interventional cardiologists, because actually we know that having demonstrating the ischemia is class 1A when we deal with coronary artery disease. But actually the point is that we don't have definitive data on the impact of using physiology in terms of outcome of patients treated by TAVI. Actually, we had to do some consideration. Because when we use FFR, let's say, index based on vasodilatation, we need to know that when we have a severe coronary artery stenosis, the vasodilatation is blunted because we have a reduced microvascular vasodilatation. And actually, this is interesting because the coronary artery stenosis works like a tandem lesion in the setting of a lesion at the level of epicardial coronary artery. So if we want to get rid of this tandem lesion, we have to treat the severity, the aortic stenosis, and then to remake the FFR, for instance, to be sure about the stability of the funding, to avoid to underestimate the value of FFR. On the contrary, the diastolic index seems to be more stable, but as I said before, we need more science to give definitive conclusion in this regard.
Yeah, very interesting. But so let's review the advantages and disadvantages of percutaneous revascularization before and after TAVR. So those who have had a prior acute coronary event, what do you believe is the appropriate timing for it?
So actually, timing is really very important in setting, and actually it's mainly depend in general. The timing of intervention depends on the clinical presentation of the patient, depends on the anatomy, and depends on the lesion complexity. These are the three overarching principles to consider. But actually, I think with the help of these slides, I think is important to be very clear also for the attenders. I think we can split this slide in two parts. On the left-hand side, you have, generally speaking, PCI before TAVI. That might be days before TAVI, a month before TAVI, or might be just immediately before TAVI. And this is the same setting, PCI plus TAVI. So actually, what is the common thread between these two, first option? Is the free coronary access. And having a free coronary access may simplify the life of the interventionalist, and actually might be, sometimes the goal to pursue. But actually, for instance, when we focus on PCI and TAVI in the same setting, we need to list some drawbacks. First of all, we have more lengthy procedure. We increase the contrast use. We have adapted at the time of TAVI. And actually, this might be, a little bit of concern when we have frail patients, vulnerable patients in terms of bleeding or things like that. So actually, when we move to the middle part, to the mid part of this slide, that is PCI before days or months before TAVI, again, we have a free coronary access. It might be important because we might have a better hemodynamic stability and procedural safety of TAVI. Let's say if we treat a proximal lesion of the left main or LAD, or, let's say two last remaining vessels of the right in the circ, it might be, easier to think about the, we can get rid of the early hazard of the TAVI. But actually, again, there are some disadvantages because we have to repeat the vascular access. We are committed to that again. Is less reliable, sticking to your previous question, Mirvat, is less reliable doing physiology without getting rid of the tandem lesion that is represented by the TAVI. So moving fast forward towards the PCI after TAVI, there are some benefits for sure that we may increase again the hemodynamic stability, and we may reduce the contrast use again compared to the concomitant PCR or TAVR. But again, we have, the main drawback. The main drawback is not free access to coronary, depending on the type of THV that we use in these patients. But generally speaking, what we can say to our friends, peers, and attenders of this meeting, that the PCI before TAVI, by this consensus, is recommended according also to the ES guidelines when we have a severe lesion, proximal lesion, of the epicardial coronary artery. I would like to recall that in France too, at 3 years, there was a major impact of previous revascularization with LAD. So this matters a lot sometimes when you have very significant lesion in the significant vessels. Secondly, ACS, because the reason of the admission is the coronary, is not the severity of aortic stenosis. angina, the presence of low threshold angina, or lesion that are above 90%, because we know that in this case, we don't need proof of ischemia, we don't need physiology, because in almost all cases, when you have a proximal lesion of 95%, actually the ischemia is there.
Well, thank you, Giuseppe. And I'm glad you clarified that its clinical presentation is important. And then, we need to be very clear about the definition of severity of coronary disease. So, as we move on, when planning TAVR in those who require coronary access and PCI, are there any device-related criteria or implantation criteria that you actually recommend? And then just kind of to follow on that, we review the challenges of coronary access with the different devices, perhaps?
This is the real, this is a real central question. So, Mirvat, if we can share, thank you, please, thank you. So actually, I would like to go to start my discussion, my answer with the conclusion of my discussion here. That is, at the end of the day, to be very pragmatic, we have to think that if we have a valve that stays below the coronary artery, like the surgical valve, and in this case, this is the balloon THV valve. Actually, it's the life is a little bit simplified in terms of coronary access. And the second point is that if we decide for other reasons to select a sacrospandable valve, it's important to have this valve oriented. So this is the general conclusion for your question. But actually, I think it's important to clarify 2 or 3 concepts for the attenders. So first of all, as you can see here, from A to D, we have different frame design. And actually, what is important is not only to look at the height of the valve, like in A. Here it is clear that we are below the takeoff of the coronary arteries. When we look at the others, as you can see, we need to focus on at the height of the commissure. Why is important the height of the commissure? Because there are sewed, the leaflets. It means that this is the wrist plane, let's say the coronary wrist plane, the level above which is easier to get through the coronary, and below this, it might be a little bit more tricky because we have the leaflets, and actually we have to consider that the commissure need to be aligned with the coronary, orientated compared to the coronary, because if we have this commissure in front of the coronaries, it's going to be a mess because we need to have other strategy, let's say extra backup, different wire, different tricks to get through, and to cannulate and to go ahead with the PCI, for instance. That might be, pretty much complicated. So the first thing is the height of the frame, the height of the commissure. But at the end, what is important, down here in this slide, is the positioning of this valve. If we go deep in the ventricle, we can stay below the coronary artery more easily. If we stay, let's say 90 to 10, sometimes also with the balloon expandable valve, we are above the takeoff of the coronary artery. So again, the positioning matters a lot on top of the, the design, the matrix of the valve on the bench. Finally, last comment is when you look in green, the cell design is totally different among all the valves at THV. Once we have more closed cell design, like the core valve, or we have more open cell design, or really open cell design, like the Artery Neo in this regard. And actually, this matters a lot, again, in the general context of the patient that you're going to treat.
Well, again, thank you very much. This is very clear, and it really illustrates that operators need to understand the intricate differences between the devices when they're considering access. So, in your opinion, just for the junior operators, what are the overarching principles to improve commissural alignment and hence coronary access for patients?
Thank you. Thank you. Again, this is the immediate consequence to the previous question, Mirvat. So actually, again, I like to talk about overarching principle because at the end, we need to be as simple as possible, avoiding to be simpler. But actually, as simple as possible is always, I think, a goal in our activities, everyday activities. So the general principle is that we start with a pre-procedural planning. In the pre-procedural planning phase, we need to find out the correct three-cusp view and cusp overlap view. These two views are very important because these two views permit to us to orientate the valve to not be too much high or too much low as compared to the virtual buzzer ring, avoiding also the pacemaker rate. That is another goal that we need to follow. But actually, when we turn out to the procedural part of the procedure, there are some tricks that we need to know depending on the valve that we use. For instance, on the left-hand side, A, D, and G, panel left, 3 panel on the left. So actually, this is the core valve. The recommendation is to start with the flash port at 3 o'clock. When you start with a flash port at 3 o'clock, actually you are, let's say not pretty much sure, but you can be confident that at the end, when you go through the aorta and you cross the arch in LAO, actually you have the head marker. The head is on the right-hand side of the screen. And when you move from the three-cusp view to the cusp overlap view, you are center front with the head. In this case, you're pretty sure that the commissure is between the right and the left cusps, and you are very well oriented compared to the coronary axis. This is for the core valve. When we move to another valve in the middle of this slide is the accurate neo, the flash port has to be at 6 o'clock. Because when you go at 6 o'clock, there is a very high likelihood that you finish up in the cusp overlap view in the panel E with the fistulas that here you can see, that is towards the right-hand side of the screen. This means that the commissure, again, is between the right and the left cusps. And this is the right way to deliver this valve. And to conclude, when we move to the navitor, the flash port needs to stay at 12 o'clock. It's like having, different jet lag. This is interesting. You travel around the world, you need to know different time. And actually, it's pretty much the same. This is the jet lag of using the different valves. And actually, you have to start at 12 o'clock to meet this configuration. It is in the F panel. You have a slit-like in red, a picture of the commissure, and the bold, thicker, two slits-like. That means that the commissure is on the right-hand side of the screen in cusp overlap. And this is, again, my guarantee to you that when you go for selective cannulation, you won't have any.
Perfect. Thank you so much. And we've focused so far on the valve, the implantation, and so on. But something else to bear into consideration is actually the relationship of the skirt, the new skirt, and the dimension of the sinotubular junction. These are two important determinants as well for coronary access. So, what role do those two in particular play as well?
Thank you. Actually, I think this is something that is the lifetime strategy in a patient. So, because I think one of the central role of the heart team is to deliver a strategy, not a device, a therapeutic strategy in this patient that has to think not just at the today or tomorrow, but need to think at the potential lifetime strategy in this patient. That in, let's say, 88 years old, man, it might be 3 years, 4 years. But actually, when we treat 70 years old, man might be 20 years. So actually, we need to be safe in this decision, and we need to take into account different things. So what are the 3 challenges that we have to consider when we focus at the further permutations in terms of lifetime strategy and when we deal about coronary access? First of all, the three challenges that we have already seen are the leaflet side, the wrist plane, the so-called wrist plane. The second point is this asymmetric commissural level that goes with the need for orientation of the valve. And the third point is the cell design. So based on these three things, we can find out three different combinations. The first one, top level of the slide, that the first valve, for instance, is a short valve and the coronary ostia is above the new skirt. What is the new skirt? Is the covered stent that you create when you go with the TAVI ring TAVI. So when you tilt up and displace up and outward the leaflets, you create a covered stent. So this is, in this case, when you start having a short frame valve below the coronary, then you can go with, let's say, an intraannular valve, short valve in a short valve, or you may go with a self-expandable taller valve in a short valve that is going to be oriented, and in this case, you won't have any problem in terms of coronary access. Scenario number two, that is, you might have, let's say Sapien or Corvallo or Navit or whatever it is, the coronary ostia is below the new skirt because the implantation is too high, for instance, in case of the Sapien, or, for the taller frame valve, it's, the vast majority of case is this scenario, based also on other paper from Ochai, etc. So actually, in this case, what is extremely important is to have a dilated aortic root. Because when you have a dilated aortic root, you might go with a self-expandable, with a short valve in a short valve, or you might go with a taller valve in a short valve, or vice versa. And actually, the point is that when you have an extra space outward of the frame, the coronary access may be guaranteed. On the contrary, when you go with a too taller valve and you don't have an extra space at the level of ascending aorta, it's very difficult to get through, with the catheter and to cannulate the coronary, even though you go with basilica. Why that? Because when you have a closed cell design, you might have a misalignment of the cell, and actually, even though you get rid of the leaflets, asymmetric skirt and all these things, might be very difficult to get through this really tight net that is created by the two level of cell design, the level of the closed cell design of the two frames. Finally, this is the most dangerous situation. When you put a valve, because you don't think at the lifetime strategy, you have small annuli, you have a small ST junction, and you won't go for surgery, and you decide to go without an accurate heart team discussion for a TAVI. Whatever it is, is Sapien or taller valve, actually in this case, that you touch with the frame and with your wrist plane, the ST junction. At this point, when you go with another valve, you create a sinus sequestration, and this is a big mess. Because in this case, you have to go for TAVI explantation. That this is, at the end, the real failure of the heart team discussion and lifetime patient perspective. During the index, the first discussion, the lifetime strategy in this patient, because the TAVI explantation is the worst scenario for this patient in terms of outcome, because the mortality is 13% at 30 days and 30% at 1 year.
Well, thank you very much, Giuseppe. This has been very educational, and I think our take-home messages here are there are patient factors, presentation, anatomy, and then operators have to have an understanding of the devices and their unique design and implantation techniques that can preserve access or improve access in the future. Well, thank you everybody for joining us on another episode of EIJ on Air, and we hope to see you again. The article is published on Neurointervention. Please do look it up for more details.
Thank you.